Pec. There we go. How is it? Just tender where she's pressing?
Pretty much everywhere.
Okay. So what I would do? Do you have a pillowcase?
It's this one, but
So we have an additional one or something? So I just want you to try it with a pillowcase just to see.
Yeah, I was like, I have bony elbows.
And fold it, yeah, fold it. And that's the thing, you have smaller arms, right? So the thing is, that's why I say knee. How big is a knee? How broad is a knee? Aha, there is a method to my madness, trust me. But when you use this, that's going to dampen just a little bit. Now try it and see how it feels. And then this is totally different than this. Yeah.
So,
a little bit better.
A little bit better? Yeah. And if you had to, you could double up. You could grab another one.
okay, but
Or a towel, yeah.
So he's experienced a lot.
Totally fine. Okay.
A lot of pain.
Where he presses.
Yeah,
Just tender? Okay.
that's all.
So what do I mean, am I at the right angle?
So when we think about arm, I'm going to make sure the camera catches this. So do we use this point? Do we use right along the ulna?
no.
Or do we use more of the forearm extensors? Do you see the difference? Real subtle difference, but you know these tools. I would, if it's too sharp, I want you to broaden and use this. And also, if it's still too sharp, if it's still too much, we need a pillowcase, we need a towel. I love how you use the sheet. You understood what I was doing. Use what's available. How's the pressure there now?
This better.
Better? Okay. Now, could you use your hand right here the same way? Sure. Absolutely. Yeah.
She needs to be in a position where she has the knee up here because she was on the table.
Okay.
And I can't direct her from here. She's doing the pool.
How's that right there, brother? Is that too much?
Not enough.
Now, when I give cues, by the way, and I say, is it too much? I don't say, is it my knee, or is it my foot, or is it my left, or my right? The clients get totally confused because eventually I'll make 3 or 4 points of contact. I'll say, is this too much?
No.
Okay, how's this?
I don't feel like anything's being done.
Okay. So I'm going to prop him here. How's this?
Oh, yeah, that's better.
There we go. Okay. And I'm actually going to roll him just a little further forward. How's that right there? How's that? There we go. So now when we make multiple points of contact, if they feel it more in the lower back, is it good or is it bad? Good. Well, you're just mobilizing. Like, does it feel good?
Yeah.
Okay, good. If it feels like they're getting a release, here's the thing. We're not just working pec. We're not just working the shoulder. We're working the spine. You're working the lumbar spine. The knee was in the gluteals. There are times where I will do 2 or 3 different things at once, and from those 2 or 3 points of contact, I can toggle from contact point to contact point, depending on the pressure I want to give. How's this here? Does this not feel as sharp? There was something about the angle where it looked like this was going to be more broad.
Well,
Yeah.
I think, well, the pressure he was given was really this way instead of toward this way.
Yeah. Once he's in position and he's delivering compression, that's where I would give you the choice. So once we found like a comfortable amount of pressure, then I'd say, hey, do you want more pressure to the posterior or do you want more pressure to the anterior?
Okay.
Do you want more pressure like down towards the feet? Do you want pressure up towards the head? Normally, it's just giving them a choice.
Okay.
Part of the reason I do that is I just want to engage their nervous system. When I work on you and we work on deltoid, it's like when I get into a spot and I go, oh, right there. You know, I'm like, okay, do you want more pressure to the back or to the front? Do you want more pressure down towards the elbow or up towards the shoulder?
Down. Yeah.
And the thing is, when I give you the choice, I think it puts you in more control. It means we're working together.
Right.
And it's engaging you.
Yeah.
I don't want to use too much pressure, but using too little pressure means I do nothing. When I started with him, he's like, he ain't doing nothing to my shoulder. It's like, this is useless. Yeah. Is it better now?
It was, yeah.
So when you're this way,
Yeah.
do you just put their arm down?
I will, and what I did in her case is because I took the arm out. So I put her at neutral like this. So go ahead and lean in again. And now what happens is I can use this hand to start a roll. Because I get a handle to be able to roll this open. Think pin and stretch again. Now it depends on him. He might like jostle.
Oh no, this feels.
He might like just straight compression. Everybody's going to be a bit different. What I used to tell students is that muscles cause movement, and we use movement to access those muscles.
Okay, I'm trying to get my leg up for the glute, but is this?
So what I did was the upper glute. There you go. But my hips are higher than yours, right?
Yeah, like
Because I'm a little bit taller.
like almost in the arm.
So let me step in real quick. And I just did it because, but I'm a different height, right? For you, we might change this. I'm in the upper. How's this right here? Not too much? How's this? There we go. There we go.
It's supposed to feel like.
There we go. Now, is it too much here?
No.
Was it too much here?
No.
Okay. Now, if I can't do that, even because of the table height, like I had to reach up, it's not wrong if you do it here, but how much twist does she get? Because I'm anchoring the side that's up and then pulling the side that's up, I'm getting more twist there. In your case, I would probably come along like this. And that's going to isolate her some. It's not going to give her quite as much. She's not going to get pressure in the gluteals. The other option is this. You can take her like this. Same basic idea, just different body mechanics. How was that? Good.
Everybody's real twisted. Yeah.
So I'm, yeah.
So when you press into the front, into the pecs, what do you access? When you press into the front, what are we accessing? What are we pressing on? Pec and pec minor. Pec minor is the bitch. Sorry. Pec minor is the one. Pec minor is why we need to learn how to use the knee. Pec minor, a lot of people when I do chest work on them, they just cannot believe afterwards that their shoulder blades are that mobile. Pec minor is the one to me. The pec is a problem. The pec minor is just glued. Not a lot of mobility.
Can I come a little closer to her when I get work? This
Sure. So
I think the table's a little high for me, but
the work will become increasingly intimate. I will snake all over your body for 3 hours.
that's wonderful.
I will use my legs, knees, feet, traction joints, move you around, compress stuff, all of my body. Increasingly physically intimate because there's more physical contact.
Are you okay?
But we're both clothed. It's a different art form. It's a different art form. You were a boxer.
Yeah.
Massage therapists are boxers.
Yeah, it takes its toll on your body.
What I'm teaching is Brazilian Jiu-Jitsu. I have an entire industry of strikers. They don't even use their legs. They're boxers. They come in and try to hit me, fist. They have a jab and an uppercut, jab and an uppercut, jab and an uppercut. They tell me their hands hurt. And I say, come at me, come swing at me. I dodge a punch, put them in a chokehold, bring them to the mat, wrap my legs around them and go, I'm going to rip your arm off unless you tap out now. It's over. That is what I teach. That is what I teach. It is more effective for the clients and it is less intense for you. You can do it until you're dead. How we doing? So instead of hand, let's try to get your, yeah. No, and the thing is, I think this is just, it's more oomph, it's more body. Yeah. And then it allows you to get that more torque there. How's that? And that's it. Because you'll still use these, but I'll get you to save them as much as I can. How we doing?
I feel like I have the wrong arm.
No. So if you do both, I'm going to wrap the forearm here, and now you can get the twist that way. There you go. We have a thumbs up.
That's elbow.
How we doing? We okay?
I was going to ask a question.
Not too sharp?
It's a little sharp. But work with a person that's psychologically uptight.
Okay.
Real tense.
Real tense.
How you work with those kind of people?
Psychologically uptight, very tense people, constantly stuck in their thoughts. How do you work with those people?
Very slowly.
The people who can't let go, right?
Yeah, they're kind of like they're stuck in this zone and they can't, like touching on their really.
Yeah.
There's a lot of emotional trauma in that area.
Move, mobilize, jostle, shake, move, compress, mobilize, shake, jostle, move. So when I worked as when I worked as a therapist, like I stopped. The thing is, when I would work in a facility doing table work, I would like move the person's arm, and I'd say relax,
Relax.
and they'd say, I am relaxed,
Relax.
and I'm like,
I'm just helping you.
no, like relax. And here's what I learned. You don't tell them to relax. What I do is, he's keyed up, and I go, listen, are you still having problems with your upper back and neck? Is that what the main problem is?
Yeah.
How's this in here? Do you use your hands like typing? Okay.
You're right. A lot of times you can just
Right in there?
without saying a word.
Yeah.
And they'll relax.
Yeah.
And how's your, ooh, man, yeah, you do type a lot. Wow, okay. Now, I'm still primarily working here, but what happens to his shoulder blade? What happens to his neck?
Yeah. You're moving it all.
Because I'm working on his neck primarily.
Yeah. He doesn't know that.
He does, but that's the thing, that you trick them. You trick them. Because the thing is, that's where, as a mechanic, they're coming to us to fix the car. They came to us because they don't know how. They don't know what's wrong. We have to educate them. And part of that is like to get away from the verbal part for some people. I mean, you do want to communicate effectively verbally, but when he's saying, when they're keyed up, what do I do? Lots of jostle. Jostle, shaking, mobilization, constant.
Okay, I got someone that's got intense. They're really tight through here, the scalenes and
Yeah.
occipitus. Occipitus was really tight.
Yeah.
Right through there. And to constantly, and I'm kind of almost like, don't know really how to approach to work on because it's kind of like anything I do seems to make it worse. So they get really, it's more emotional. To me, I think it's more emotional trauma than
So,
psychological. More than,
with them, my first thought is you lessen the compression and increase mobilization.
so if you're working on the occipital through here, because they're always doing this, trying to release because it's all through here.
They're having temporalis, they're clenching their jaw, they're having suboccipital issues because they're jetting their chin forward.
Yeah.
I use lots of just mobilization. And then literally I'm just improvising off of this and I go, hey, how's that right there? Is it too much in your suboccipitals there? Okay. Can you press the back of your head into my hands? There you go. And relax and let go. And you'll see I didn't give you a whole lot more, but like that sort of engagement and mobilization, I'm just trying to mobilize their neck and like move that around in a gentle way. What I do notice is this. You see how I said we backed off of compression? It's not that one technique is superior to another. It's that some people respond to different things. You have somebody with, maybe they have emotional, psychological issues. They don't trust very easily. They're a holder. I can usually, if I go in for a compression, my first thought is they're going to tighten up to protection. That's where I'd be much more slow with them and start off with like more gentle rocking, mobilization, working back to that, and then mobilizing and kind of working the neck in the same way. See, it's not very deep, right? Yeah, that's probably where I would start with them.
Plus, when you did the stretching, you said, pull your head back. It gave them
Little
a little bit
engagement.
of control.
Yeah, and the same thing I did with whoever I worked on. It was you, Brenda, that was right. When I worked on Brenda's arm, when she was mobilizing it, and we had to take that piece out because it was just a little too much. It was too much compression. It's about giving them, even with compression, let's say we pick a tool, it's not about giving him the max we can give him. It's about giving him enough so that you can release and relax and unwind. And that person you're talking about, same thing. They might not want compression at all. The mobilization
That's what I'm concerned about. 'Cause I
and lengthening.
feel like, you know, it's a challenge.
Yeah. And always will be.
When you're in the middle of doing a stretch, I know it's the body's natural, trying to find the right word, resistance. Is that normal? Should you put more resistance?
So long term, it's like when you put your elbow into somebody's paraspinals, how much pressure do you use?
Depends.
Because you learn that the tissue texture changes. When you start using mobilization and lengthening, you're going to learn what normal, quote unquote, range of motion is for a shoulder joint, what normal range of motion is for a shoulder blade, what normal range of motion is for a twist. And then you're just encouraging somebody to let go and release. But it does take some practice to get like a sense of feel. I'm not just trying to take them to their extreme end range immediately.
Softly and then gradually add.
I really think the way to go deep is to be soft. And if you ever get a session with me, you're going to laugh that I said that. Because sometimes to find your edge with compression, I have to go a little bit over and then go, oh, it's too much? How about there? And usually that's the point at which it's perfect.
When are you going to talk about scar tissue if you are at all?
Okay, so what about scar tissue? What about scar tissue? Let's talk about scar tissue. What about scar tissue?
It's painful.
It's painful. Okay, so what if we work near scar tissue?
Would it be best to work directly on it?
I don't know. What do you think? It depends on how you feel. And the thing is, scar tissue, like, it could be anywhere. So the thing is, when scar tissue forms, is scar tissue contractile? Muscles contract and relax. Does scar tissue contract and relax? Is scar tissue innervated?
Does that mean this?
I'm asking a question. Innervated? It means does it have nerve supply? Because muscles have nerve supply that tell the muscles to contract and relax. Does scar tissue have nerve supply that tells it to contract and relax?
No, right?
I think the answer is no. There are nerves that run through the area. Does scar tissue cause pain? And is it from the scar tissue itself? I am asking questions. Don't feel ashamed. Like if you there's no wrong answer. I'm actively asking questions and I make everybody angry. I'm going to work as close to the scar tissue as I can get within your comfortable range of motion. And because I'm not an expert in scar tissue, I'm going to let you teach me about it as we work on it. And I'll find out, do you want sharp pressure? Do you want broad pressure? And then from session to session, we'll tweak it to make you feel better. What I can also say is if she has scar tissue, she may respond completely differently even if she has scar tissue in the same spot. It's so variable from person to person. My understanding is that any change in scar tissue happens because the nervous system allows it. Any change that happens in muscle happens because the nervous system allows it. Any change that happens in fascia happens because the nervous system allows it. The nervous system is primary. What I have to do is connect with the client. So I like compression. I like deep compression. You guys ever had craniosacral therapy?
No, I want to learn that.
Extremely gentle holds. Almost no movement. Sometimes. Is it more or less effective than compression?
More.
It's the same.
It's deeper.
I think it's the same. I'm not teaching you a technique. I'm giving you tools, but the thing is, I don't think it's necessarily superior. It depends on what they respond to. Make sense? And that's the thing. Like with her, maybe she's like, no, the compression is a little too much. She wants lighter, gentler, more gentle mobilization, right? And then when I'm dealing with scar tissue, then I'm going to ask, how did you get scar tissue? Was there an accident? What happened? And then it's like, okay, because when you have scar tissue, okay, did you have like a muscle tear?
What are you saying?
You're asking me?
Yeah.
Yes.
Okay. What happened?
I was ran over by a trailer.
Okay. You were run over by a trailer, and what tore? Do you know?
It was the upper trap,
Upper trap. Okay.
and then it was a hairline fracture of the clavicle.
Hairline fracture of the clavicle,
That's you?
and then upper trap tore. Now, did the tendon
Got ran over by a trailer.
did the tendon tear or the belly of the muscle trap?
It was the belly of the muscle.
Okay. My first thought, belly of the muscle of the trap. I'm going to work around that to the degree to which she can take it, meaning I'm not going to give you too much pressure. Then she had a hairline fracture at the clavicle. Immediately I'm going to check pec. I'm going to check pec minor. I'm going to check subclavius. And subclavius is right underneath the clavicle. She probably has some issue with that because that muscle was like, do I work or do I not? It broke, the clavicle fractured, right? I'm going to work all of that. Then when it comes to the ribs around the area, I'm going to wind up working the scalenes because they attach on the first and second ribs. I'm going to work all around the front and the back for that particular area related to that scar tissue. My goal in session is, do you have pain from that? Okay, what's your pain level at? Like 10's hospital, 0's no pain. Given day, give me an average.
It varies anywhere from 6 to a 7.
6 to a 7, pretty bad. Where's it at right now?
Probably 5.
5, okay. My goal in session is to reduce her by 2 points on a pain scale. I will tell her that initially when I do my intake. My goal is to drop her by 2 points on a pain scale. Now, when I drop her from a 5 to a 2, she's going to feel like it was a miracle. And we may be able to do that, but I'm trying to give you reasonable outcomes and expectations. I know, I wanted to cancel class and just work on her and be like, watch. Because that's how I work. I don't really work in forms of like sequences, protocols anymore. Like that was all destroyed a long time ago. I give time massage sequences, 700 pages worth, 9 DVDs of content, and then I keep going. I'm documenting more because what I would do, where do you live?
Cumbie.
Cumbie, where's Cumbie?
On the other side of Greenville.
Okay, so how far is it from here?
An hour and 45 minutes. I was stuck in traffic.
So whenever I have an intro class and she knows that I'm coming to town and she says she wants a session, I'll set up my camera, record the entire session, and then upload it to the subscription service. Because I don't have any content related to scar tissue specifically, and she has a specific need, and it allows me to work on you and also educate the audience about how I'm accessing those things. Students on the subscription, we're asking for prenatal work. How much prenatal work do I do? Pregnant women are not coming to me and going, stand on me, right? So what I did was I found a student in class, and another therapist recommended their daughter who was like 4 or 5 months along. And essentially now what I'm doing is I'm giving her a free session for an hour once a month where I'm going to document her entire pregnancy and then after the pregnancy to show how I work on those issues. Yeah. Yeah.
That's why I think I guess it could still be back here.